I'm Daniel Bravin from Springfield, Missouri, not Springfield, Illinois. And I'm going to present a case that kind of got me started on CurvaFix. I had a hard time coming around initially when I first heard about this implant. And it started with, for me, for problems without solutions. So there were a couple of these, but I'm going to highlight one of them today. Parasymphyseal fractures. They're challenging to deal with, and the options are anterior column screws, infix, xfix, or AF. So all three of these are patients that I've treated with different techniques. So this is an example of one of the problems that I ran into. So I thought this looked good. A patient that I treated several years ago, a bicortical anterior column screw to a parasymphyseal fracture. At follow-up, this is what it looked like. So she displaced through it. Her screw loosened a little bit in the back. You can say maybe it needed more fixation in the back. I don't know that it would have made a difference in this case. But to me, this is a problem that I didn't have an answer for. So this is a more recent case that I've done, but it highlights kind of this problem. So this is a 63-year-old male, motorcycle accident. He's an ex-professional dirt bike racer, and he loves telling everybody that. He had multiple other injuries, but he has this complete sacral fracture and bilateral superior inferior ramus fractures and kind of this saddle injury that you would expect from a motorcycle. So the options here, kind of like we talked about before, the anterior column screws, infix, xfix, or AF. And I thought this was a great opportunity to use the CurvaFix and show how beneficial it is in these type of situations. So these are just some fluoroscopic images from this case. So started by fixing the back, and then you can see the displacement in the ramus in the top left picture. So it's a pretty standard starting site for an anterior column screw. And then going down with the steerable guide wire, being able to manipulate it and kind of rotate it back and forth and kind of get it got down into the ramus there. And then one other technical thing here is in this parasymphyseal bone, especially in younger patients or not the non-geriatric patients, this can actually be pretty good, and it's hard to get that steerable guide wire out. So what I do is take a drill bit and actually push it down kind of as far as it'll go straightly, and it stiffens this construct a lot as you mallet that out. But then get that bicortical. I think a big key is being able to get it out bicortical, reaming bicortically to get the threads engaged into the parasymphyseal bone. And I try to kind of dock that anteriorly and caudally, and it catches kind of the intact bone of the fracture. And what you can see here, the difference is as it goes out, it then expands, and you can actually compress back through it as the proximal end of the implant hits the ilium. You just have to be able to measure it correctly so that it doesn't protrude too much there. But you can actually get some compression through the implant too, which is really cool. And you can see the amount of curve on that going through this displaced ramus fracture. So then similar on the other side, that side wasn't quite as displaced, but placed another CurvaFix there, and you can again kind of appreciate the dramatic dip that it does to catch that intact bone there. And so this is what it looked like at the final AP. And this allowed me to not do any incisions anteriorly. This allowed me to do all of it closed and be very comfortable with my fixation on this. And I tried to get the images, but it doesn't really show it very well. But I can tell you when you stress this afterwards, every time I finish one of these, I stress it afterwards, and you can't even get it to move. You go on live fluoro and you try to move it, and it's not moving after this is all fixed. So this genius was going to weight bear as tolerated immediately anyways, whether I said not to. So I let him weight bear as tolerated right away. This is his 8-week follow-up, and he's already making a bunch of callus, no assisted devices. He came in at 2 weeks, asked for more narcotics, and I said no, and he was like, okay, I don't need them anyways, I just wanted them. So this guy, he's that kind of patient. But it's, yeah, so it was a very powerful implant for these type of fractures for me, and this is just a couple other ones that I've done with similar ones. Type injuries, and it just really changed the way that I've treated these fractures. I've become very comfortable letting all these patients weight bear as tolerated right away, whether they're elderly or younger, high energy injuries. This is kind of a myriad of different fracture patterns that I've used them for. So just one example of how this implant can really help you with fracture fixation.